Big. Okay. All right. So we are going to talk about restless legs and dopamine agonists in particular, and how we've been using them quite a bit over the last 15 years or so for restless legs, and why it may be time to think twice about that. I do have a disclosure. I'm grant funded by Harmony Biosciences, and they are funding a trial of restless legs. That's not what we're talking about today. My funding has nothing to do with restless legs, so it's not really a conflict of interest. And we're going to be talking about a lot of off-label uses of medications today. So this is why we're talking about restless legs. I've heard all of these quotes in my office. I'm going to cut my legs off if you can't find something to fix this. It's worse than their chemo for cancer. And I'm not going to do this. I'm going to kill myself if I can't get better. The key to all three of these comments is that all three of them were actually being treated for restless legs already before I saw them. This was on treatment that they were saying these things. So it's miserable, and it's miserable, even sometimes more miserable for people who are actually on treatment. So let's start with the basics. We're going to just do a quick review of restless legs. Usually come and talk to the residents for noon conference each year, just so you know, this is going to count for that. So you're not going to get a second talk with this stuff. So if you're a resident out there, this will be your tour of restless legs. We also call it RLS, as you know, but Willis-Ekbom disease, that came into fashion a few years back, and then it quickly fell back out of fashion because it's kind of silly to go backwards from a descriptive name to an eponym where everything else is going the other way. But they decided to use that term Willis-Ekbom disease because they thought people weren't respecting restless legs enough. And while true, I'm not sure giving it that name actually did anything to improve people's sense of how important this is to actually treat. So it came and went, but you may see it in the literature if you're reading studies on RLS. The diagnosis is actually relatively straightforward. The definition is an uncomfortable sensation, often an urge to move, which is worse in the evening or at night, worse when you're resting, and better when you're moving. That's it. And then, of course, the final criteria, not better explained by something else. But those are the four diagnostic elements of restless leg syndrome. What it is not is an unrelenting pain and dysesthesias that go on all day. Think something else. This is a very circadian disorder. So all day symptoms are not usually restless legs. Abnormal movements in bed. A lot of things cause you to move in bed. Restless legs is one of them, but just because you're moving in bed does not mean you have restless legs. And what we're looking at on a sleep study are periodic limb movements, which can exist independent of restless leg syndrome. So periodic limb movements that we see on a sleep study do not diagnose RLS. And any of you, Chris, you're doing a great job of that right now. The bouncy legs, not restless legs. Think of RLS as a sensory motor problem, with the sensory being a lot more prominent than the motor. You don't actually need a motor component. It is a sensory condition. And that means it's subjective and not based on objective testing. So if patients report the symptoms, that's sufficient. So we start by getting the history, and if the patient meets criteria, we can usually make the diagnosis from history alone. There really isn't anything on physical exam you're looking for other than confounding factors like neuropathy. So you may pick up a loss of sensation or reflexes. You don't need any labs to diagnose it, but you are going to check labs because you need to know about iron. We're going to talk more about iron later, but you don't actually need a lab for diagnosis. And for anyone thinking we do sleep studies, that's just a big no, 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 no. We don't order sleep studies for restless legs. It's not helpful. And so if you meet the criteria, we make the diagnosis, and that's it. So it's not too tough. You actually can get restless legs in other parts of your body. It does not have to be legs. It's a bit of a misnomer. Legs are by far the most common, but you can get it in the arms. I have a patient who has restless back, and case reports have listed restless genitals and restless anus syndrome, which I have not actually seen in clinic, but can exist. So it does not have to be in the legs, and it does not have to be bilateral, although it usually is. And I just implore people to take it seriously because it might not be fatal, but it sure makes patients miserable. RLS is not without consequences. We think of it as just uncomfortable, but it's actually been linked to coronary artery disease, depression, and anxiety. It makes people sleepier during the day because they didn't sleep at night. There are some reports that it might increase the risk of sleepwalking, as in when you're asleep and your legs are bothering you, you get up, but you don't fully awaken. So you end up sleepwalking. That link is a bit dubious, but it's been reported, and it can certainly hurt marriages. You know, you've got one partner who wants to go to the movies and the other says, I'll never be able to sit still through a movie. It can affect travel. It can really, really take over your life, and spouses may not be happy living with someone who never wants to sit still. We're all seeing it in our clinics, whether you're a sleep specialist or not. 16% of MS will have restless legs. 30% of stroke patients will have RLS after their stroke, and you can see the relative distribution based on the location of the stroke. It's common in Parkinson's disease, although certainly not 100%, and it's not a risk factor for development of Parkinson's disease, but there is an overlap. Peripheral neuropathy is very high. A lot of neuropathic patients will develop RLS. And the rate in spinal cord lesions is unclear. I couldn't find a number, but it's often reported that spinal cord lesions can do this as well. So we're all going to be seeing it in our clinics, whether you treat it specifically or not. Let's go through pathophysiology for a little bit. And I want to do this because when you understand some of where this is coming from, it'll make more sense why we treat it the way we do. So got to start with iron, because that is the fundamental aspect of the pathophysiology of restless legs. It is a brain iron deficiency disorder. And this has been known for a long time. They found this link in the 50s. Patients with iron deficiency were more likely to have RLS. In 2000, this study out of Hopkins showed in patients without RLS versus patients with RLS, if you do spinal fluid, you're going to get much lower ferritin levels in the spinal fluid. Now, of course, we're not doing a lot of LPs on patients to see if they're brain iron deficient, but if we did, we would see substantially lower brain iron. Not only that, increasing serum ferritin does not translate to increased CSF ferritin in this population. They have a hard time moving the iron in their blood into their brain. The blood-brain barrier is not friendly to iron, and you can have mutations in those transporters that prevent getting iron in. So when we're looking at trying to get iron into the brain, we're looking at particularly high ferritin levels to be able to get CSF ferritin up where it needs to be. But even in these ranges, which would be theoretically normal, we're still talking low CNS ferritin. So when we look at the iron as the fundamental cause, the iron is related to all of the central nervous system neurotransmitter changes that occur in restless legs. And it's not just dopamine. We talk about dopamine the most, and everybody thinks of restless leg syndrome as a dopamine disorder, but that's only one small component of a long cascade of changes that happen to a brain that's iron deficient. And dopamine is part of it, but it's also adenosine, it's glutamate, and it's opioids. There are other theories that come with peripheral causes of restless legs, like peripheral neuropathy as a trigger and peripheral hypoxemia. We'll talk briefly about those. They're still debated, but I'll give you the evidence for why there's probably a heterogeneous mix of etiologies for restless legs. If we put this cascade together, the starting point is the brain iron deficiency, and that's usually due to poor transport across the blood-brain barrier. But that brain iron deficiency has two problems associated with it. One, downregulation of adenosine receptors. So these adenosine 1 receptors are responsible for helping you fall asleep. Adenosine, of course, the common antagonist is caffeine. So when you have blockade of your adenosine receptors, you're actually going to have a harder time falling asleep. And brain iron deficiency also increases glutamate, which causes hyperarousal. So now you're in a state where you're not sleeping and you've got this increased glutamate. The glutamate downstream increases dopamine release. And most people probably don't realize that restless legs is not associated with a dopamine deficiency. It's a dopamine increase, which then downstream actually downregulates the dopamine receptors. So the problem is downstream postsynaptic. And the thought is maybe the dopamine agonists are working here and actually downregulate dopamine secretion. So they have a twofold effect. Yes, they'll stimulate the dopamine receptors, but they're actually working to downregulate presynaptic dopamine release. So it's a whole cascade, and we can intervene at the adenosine level, the glutamate level, or the dopamine level to improve symptoms of restless legs. Now, I haven't mentioned histamine yet because this is still being worked out. But one of the biggest triggers of restless leg syndrome is antihistamines. Someone takes Benadryl to sleep at night and they realize that was a bad idea because now their restless legs are acting up. Where does histamine fit into this? Still unclear. But we know histamine it must play a role somewhere, but we don't exactly know where that fits in. And then the opiate receptors, where do they come in? We know opiates are related, and actually opiates and iron deficiency go together. There's mouse data to show that you actually have differences in processing of iron if you have changes in opiate receptors, and opiate receptor deficient mice that are bred that way develop anemia. So there is a connection there that isn't quite worked out. So these are still open-ended questions to fit into this model. Yeah. Yeah, so SSRIs are a known trigger. The one that actually is the antidepressant that seems to be worse is actually mirtazapine. So it's not the SSRI, but it's the tetracyclic that is even worse. But a lot of the antidepressants will cause it. Why? Again, we don't know. Serotonin isn't classically in the model either. I can give you sort of the hand waving answer that they all interact, and the serotonin going up is probably affecting the dopamine somewhere else. And it's a bit more complicated than I can work out for you now, but that's presumably how it's affecting things. And this is what I was talking about. The opioid receptors are related to iron. We just haven't figured out in humans how that all works out. So this is all mouse data. And then I said those are the central nervous system causes. We also have the peripheral causes, and there's a huge overlap with peripheral neuropathy. We talked about that. Nearly 30% of patients with peripheral neuropathy develop RLS. And actually, even in patients without known neuropathy diagnoses, if you biopsy their nerves in patients with RLS, you can see abnormal biopsies. So there's something going on peripherally in the nerves of some patients with RLS. And we all know that gabapentinoids can help neuropathy. They also help restless legs. Is there a connection there? Still to be seen. And then I think this data is really interesting, the peripheral hypoxemia hypothesis. And they've shown that if you look at the partial pressure of oxygen in the legs and compare it to the chest, for patients with restless legs, there's a drop off in oxygen in the legs compared to the chest, whereas carbon dioxide does not change between restless legs patients and controls. So there's something different in the oxygenation in the legs of RLS patients that we don't quite understand, and this is not due to anemia. Furthermore, you give these patients dopamine agonists, and it increases the oxygenation in their legs. So maybe what these drugs are doing has nothing to do with the dopamine in the CNS after all, or it just has two different reasons that these drugs are well known to be effective, that one is working in the periphery, one is working in the brain. But you actually can increase oxygen to the legs and improve RLS that way. And we know exercise helps, and that's independent of iron in the brain. So just getting more blood flow to the legs can help. So there's reason to believe that there could be a peripheral etiology for some patients. And I kind of think that not everybody's going to have the same cause of their RLS. So in terms of workup, when you're seeing these patients, the most important thing to remember is that iron in the body does not equal iron in the brain. I showed you those slides before. I don't want you to forget it. So I put a little key there because this is a key point. So what are you actually looking for on in the labs? The ferritin should be greater than 75. And when new guidelines come out, it wouldn't surprise me if that target goes up even higher, because even 75 is probably too low. So patients tend to respond best when they're really above 200. So you're going to check labs for iron, and you're going to get a patient, say 50, 60, and they're going to look great because it's well above that normal ferritin of 11. And I'm going to say that's still substantially iron deficient. They probably need more iron. The trouble with ferritin is that it's an acute phase reactant. So it's very fickle. You can't always rely on ferritin. So we always check a transferrin saturation to go with it. We want that to be above 20%. If either of them is low, we consider patients to be iron deficient, because if the transferrin saturation is low, then we just assume the ferritin is elevated simply because of inflammation, and we don't rely on it. Whereas if the ferritin is low, you can be pretty confident that the patient is deficient. So either way, we're going to have a very low threshold to try to increase iron. What about hemoglobin? We don't actually care. Anemia is not really the relevant factor here, so we don't check hemoglobin on a regular basis, because even a normal hemoglobin would not deter us from treating with iron. So just going over some scenarios, a ferritin of 25 a transferrin saturation of 25%. This person needs iron. We're going to treat. They're below 25. If their ferritin is high, their transferrin saturation is okay. That probably person may not respond all that well. Probably not going to go for iron first for that person. This person with the transferrin saturation of 15%, I'm going to suggest iron for this person because that ferritin is probably inflammatory. This person has a really high transferrin saturation, and these are the tricky ones. Why is their iron low and yet they're so saturated? This could be an issue with not producing enough transferrin, so a liver disease maybe, but we never know quite what to do with this population because it's an unusual combination of labs. But we do tend to try to treat this because even with the high saturation, they really don't have that much iron. And then you've got the high across the board. And these people you definitely don't give iron to, and you get them a workup for hemochromatosis. So we would not give iron to those patients. And you can, in fact, have hemochromatosis with elevated blood iron and brain iron deficiency at the same time, which is extremely difficult to treat because you're not going to give them more iron, but there's just no safe way to administer iron to those patients. Now, what we would really love to do someday is actually do ultrasounds. This is what they're doing experimentally in Spain. They're finding that this is far better than checking blood iron and making brain iron assumptions. So they're doing these in Spain. I don't know anyone in the United States doing this yet, but maybe someday we'll be able to just ultrasound the brain, tell you if you're iron deficient, and not worry about these labs that can be very difficult to interpret. So it is pretty cool that this exists now. I really hope I'm not expected to learn ultrasound because I've never been good at that. But it is coming hopefully soon, and that will really help us know when to target care for iron deficiency. So we're going to move on to treatment. This is kind of where we're going to focus today. I want to give you a little bit of history. Opioids were first. Opioids have been used for centuries. Opium was a great cure for restless legs for years. And people knew that withdrawing from opiates triggered this restlessness and this akathisia that you get, and you can't sit still. So this is sort of long-standing, well-known. Then levodopa was people realized levodopa could be used, and that's been decades. That preceded the dopamine agonists because it's older. Gabapentin and pregabalin were studied in the late 90s, early 2000s, and well, maybe not pregabalin first. Gabapentin came first, of course, pregabalin later, and they showed good efficacy in restless legs. They were never FDA approved for it, though, so they were always used off-label. And then ropinirole came around. It was approved for Parkinson's first, but it actually got approval for RLS in 2005. The big clinical trials that came out showing ropinirole was effective was led by a former Duke neurology resident, now in Texas, Dr. Ondo. I don't know, was anyone here? You remember? Okay, Joel remembers him. And then pramipexole came a year later, and the rotigotine patch 2 years after that. So right in the mid 2000s, we had this explosion of dopamine agonists, and they were FDA approved. Gabapentin wasn't. That was still sort of experimental and debated. And compared to levodopa and opioids, the dopamine agonist took off. That's what everybody switched to. That's what has been used pretty much first line for the last 18 years since ropinirole got approved. 2011, we got one more drug, and it's a form of gabapentin called gabapentin anacarbal, and that is brand name Horizont. So that is FDA approved, and it just goes to show that gabapentin really is effective, even if the generic form isn't approved. This form of gabapentin, if you're not familiar with it, it's absorbed and metabolized a little differently, but basically the active ingredient is still gabapentin. But for all those patients you give gabapentin to and they don't feel it, you give them 1,200 milligrams and they wonder what they're taking. It's because they don't metabolize it properly and absorb it. So this drug will work even in that population. So you can try it on even gabapentin resistant folks and it may help them. But it is still gabapentin at the end of the day with all the same risks and side effects and things. But I don't want to put the cart before the horse, because starting any of these drugs is premature until we actually get to the first line that we're going to do to treat it, which is get off the drugs that are triggering it. And right there on the list, Rich, antidepressants, can we get people off of it? Now, here's the trick. A lot of the patients come in on antidepressants and they need their antidepressants. And the idea of getting everybody onto bupropion, which doesn't trigger restless legs because it's dopaminergic, is not realistic. It won't help everybody. Not everybody will tolerate it. So what are you going to do with all these people who come in on SSRIs? You really can't fix that for everybody. And realistically, I've tried stopping SSRIs on the folks who say, yeah, I've been on a long time. I don't think I need it anymore. And not a single one of them said the restless legs magically went away. So we talk about minimizing it. We talk about getting off of it. It's not completely realistic for a lot of patients. The one way this matters is if they're under good control with their restless legs, they start a new antidepressant, that all of a sudden it gets worse. You say, okay, well, maybe you want to think about a different one. So that sort of idea, you have to keep in mind, it can exacerbate the problem, but don't expect to just get everybody off of all their antidepressants and the restless legs will go away. That's probably not going to happen. Antihistamines and pretty much any anticholinergic drug will trigger restless legs. And then antipsychotics. Now, blocking dopamine with the antipsychotics and antiemetics, that's just a bad idea for a condition that's already dopamine dependent like this. So those drugs all should be avoided whenever possible. And then on the dietary side, caffeine, alcohol, and nicotine, the big three, all known to trigger restless legs. So we try to get people to avoid all of them. And then I hear a lot of patients actually say, you know, I gave up, I switched to a low carb diet and my restless legs got better. Avoiding sugar is actually really helpful for a lot of people. And then the other half of patients will say, no, it's artificial sweeteners that trigger my restless legs. So whichever they tend to do more, have them do the other. Not that I would say you should have them eat a lot of sugar, but at the same time, both the artificial sweeteners and glucose can trigger restless legs for a lot of patients. There are probably other food triggers out there, but those are the ones that I hear about most when patients have experimented with elimination diets. So those are the ones that I would recommend, and the rest are sort of trial and error. After you're done dealing with all of that background, we can look into step 2, which is iron. And of course, you can be doing both of these things at once. You can be taking people off of one drug and getting them onto iron all at the same time. There are a lot of different iron products on the market. So I have an example here of using ferrous sulfate 325, which will give you 65 milligrams of elemental iron. There is not a lot of trial data to suggest what's the best way of treating restless legs with iron. There are a lot of studies on how to treat anemia. There are a lot of studies for iron for other reasons, but there isn't a lot of oral iron replacement data and what the optimal process is. So some data say give iron every other day. Some say give it every day. Some say give it twice a day. So that's a pretty big range of how often you're supposed to be giving iron. I argue that you don't want to give it multiple times a day. If you give iron multiple times a day, you induce hepcidin, which is the liver enzyme that downregulates iron absorption and can actually sabotage your process of trying to increase iron in the blood. So I don't tend to recommend a lot of iron, plus more iron comes with more side effects, specifically constipation. So every day, and if they don't tolerate it, every other day may actually be just as good because you don't trigger that response by the liver. There are a lot of iron products like ferrous sulfate, but there's ferrous gluconate on the market. Some patients may ask about chelated iron. Others may ask about heme iron versus non-heme iron. And we usually give non-heme iron. That's ferrous sulfate, and all these iron salts are non-heme iron. Heme iron, derived from meat instead of plants, is actually way better absorbed, much easier to tolerate, less trouble with digestion. And so it sounds great, except they've actually linked the higher intake of heme iron to various cancers. So you got to weigh the good with the bad. That's really been done more in a dietary situation, as in meat eaters are more likely to develop cancers. So whether that's from heme iron pills or the meat, still to be debated, but we don't usually recommend heme iron, even though the rate of absorption is markedly better if you just take animal product. When you're doing non-heme iron, as we usually do, you give it with vitamin C. You don't give it with calcium. Calcium will block the absorption of iron. Vitamin C will facilitate the absorption of iron. So you got to tell patients that, or they'll take it with a glass of milk and it won't do much good. Oral iron is slow, so you got to be patient with it and expect that it's going to take months to really bring the levels up. Much more data exists on IV iron. Um, I was in med school in the early 2000s. We were always taught, do not give IV iron if you can ever help it. High rates of anaphylaxis, not safe. That was a product called high molecular weight iron dextran. That's off the market. So you can be assured that the rates of anaphylaxis with the current products on the market are incredibly low. And so we have a much lower threshold now to order IV iron than we did 20 years ago. There are these products on the market. You can see them listed here. Low molecular weight iron dextran, it tends to be the cheapest and on formulary and very easy to get, except this week when I had my first ever rejection. So it's good to know insurance companies are now going to block my one cheap option. But ferrimoxitol we use regularly. Ferric carboxymaltose is in bold because most of the data is on that particular iron preparation. And then iron isomaltoside is the most recently approved one in the United States. That is also effective. We do not use iron sucrose or iron gluconate. They have high labile-free iron and they don't work well for restless legs. So if you're picking iron, just don't pick those. Doesn't matter which iron product, 1,000 milligrams is about the right dose for everybody. Some of them you give in one dose, which is the convenience of iron dextran. Some of them you break up into 2 doses like ferrimoxitol. But it's 1,000 milligrams pretty much regardless of which iron you're giving. As I was mentioning, there's a small risk of anaphylaxis with low molecular weight iron dextran and ferrimoxitol. The others don't even have that small risk, but those two have black box warnings for anaphylaxis. The more common reaction is what we call an iron infusion reaction. Can come with flushing, headache, nausea. That's pretty mild. It's not an allergic reaction. You treat that by turning off the infusion, waiting a few minutes, symptoms pass, turn the infusion back on at a slower rate, and keep going. It is not even a reason to discontinue the infusion that day. At worst, maybe you give them a different iron product next time they come in for an infusion, if they ever need another one. When might you choose IV iron over oral? I use the 4 I's. If you're intolerant to the GI side effects of oral iron, if you tried oral iron and it's not working, if your symptoms are too intense. Sometimes you don't want to wait for oral iron to work. You can go to IV straight away. Or if there's inflammation. When that ferritin level is high because of inflammation, your liver is going to shut down iron absorption because it perceives that you have enough iron. So it doesn't matter if you take oral iron at that point. The only way to get the iron in would be to do an iron infusion. If you've got a low transferrin saturation, but a high inflammatory ferritin, we would use IV over oral in that case too. So before we even get to the drugs, we have to remove the triggers and we have to fix the iron deficiency. That is the starting place for all RLS management. But then there's pharmacotherapy. So let's get into the options for pharmacotherapy. And what we're going to talk about is consistent with both the AAN's guidelines and the American Academy of Sleep Medicine guidelines. They're pretty similar because there aren't that many drugs that we choose anyway. So everything I say is consistent with the guidelines. I'm not going to tell you anything that's totally off the books. I conceptualize our options into 4 categories. There's the classic treatments, the common treatments, the complex treatments, and the creative treatments. Classic is the dopamine agonist. That's where we're going to start. But at this point, we're trying to encourage people that the gabapentinoids ought to be the more common therapy in this day and age. And then there's the complex patients who need the opiates. And then sometimes we have to get creative and look to some of our other medications as options for treatment. And we'll go over those as well. How do you pick one? Well, if you need help with the diagnosis, it's usually pretty clear that someone has restless legs by their symptoms, but it's not always, especially if it's like a restless back syndrome or something that's not quite clear. Sometimes you need help with the diagnosis. And I'll say in that situation, I definitely choose a dopamine agonist first. Dopamine agonists don't do a lot of other things. So if it works, you're on the right track. Then you know you're dealing with restless legs because it's not going to fix anything else. Gabapentin, you know as well as I do, gabapentin fixes everything. So you don't know what you're treating if you've given gabapentin and they get better. Is that something neuropathic or what? So if you really want to use a drug as a test, the dopamine agonists are your better option. After that, you're looking at the side effect profiles with the patients, weighing your pros and cons, and then comorbidities. Are there reasons to choose one or another based on comorbidities or any specific contraindications? So what are those potential complications? Gabapentinoids you're probably pretty familiar with: weight gain, sedation, peripheral edema, depression, cognitive impairment. Those are pretty common with any of the gabapentinoids. The dopamine agonists have their downsides too. They can cause a lot of nausea. They can cause sleep attacks. And I've seen patients on high doses of dopamine agonists who come in for a consult for narcolepsy. I say, you're not on narcolepsy, you're just on 5 milligrams of Mirapex. And stopping that will actually stop those sudden sleep attacks. They can cause a lot of orthostatic hypotension. And then the big ones, the tolerance. So dopamine agonists don't work forever. You got to increase the dose over time. And then the two dreaded complications: impulse control disorders and augmentation. We're going to spend quite a bit of time talking about those two. Augmentation. What augmentation means is that the symptoms of restless legs start to creep up on you earlier and earlier in the day. Restless legs is a circadian problem. It is a nighttime problem. If you're having symptoms throughout the day, as in you go to work, you sit at a desk and you can't manage to get through the day, almost always you've already been treated for a while with dopamine agonists, because maybe you can't get through a long flight during the day, but you shouldn't be day-to-day affected in the mornings and afternoons with restless legs unless you've augmented from being on a dopamine agonist. The symptoms are going to get more intense and they're going to start to spread. So maybe you started with restless legs and now you have restless arms and legs. All of the quotes from the 3 people I showed at the very beginning who were miserable, they were all augmented. That's what happened to them to make them this miserable. It's because they'd been treated for years with these drugs. And it occurs with all dopamine drugs. The worst of them for this is actually levodopa, which is why the dopamine agonists actually were preferentially used over levodopa, because levodopa augmentation starts earlier in therapy. You can't get away with it for as long. With the dopamine agonists, you can usually get more like a year or 2 in before the augmentation starts, although that's highly variable. But levodopa can start within a month or 2. So we really don't like levodopa for daily use because it's the biggest trigger for augmentation. But augmentation, even though it can start within months, can actually occur anytime during the course of therapy. Maybe it's 5, 6, 7 years in. The theory behind what's going on with this worsening of symptoms the longer you take it, you have to think of it as you're starting at a hypodopaminergic state. Even though you're producing more dopamine, your receptors are downregulated, you're sending less of a dopamine signal. And so you give an agonist, but that agonist, now you're adding exogenous dopamine, which leads to clinical improvement. Inevitably, every time you go up on a dopamine agonist, people feel better. But that's going to suppress further their endogenous dopamine production, and they're going to go right back to feeling bad again. So you say, oh, okay, well, you must need more. And it's a vicious cycle, and people get up to higher and higher doses of these dopamine agonists because they're just taking more and more of the drug, and it continues to suppress their endogenous dopamine. We've got to treat these people by detoxing them. The only way to get them to feel better is to detox them from the dopamine agonists. And inevitably they tell me, oh, I didn't know that this drug could cause that, because people aren't warned. There are 2 ways of doing the detox. The Hopkins and the Harvard, I named them that. That's not really their names, but that's the big RLS folks at Hopkins. Chris Early, he advocates the rapid protocol. John Winkelman at Harvard advocates what I call the more compassionate protocol. Most of us at Duke are using the Harvard protocol. What the difference is that at Hopkins, they will rapid detox you. You'll go into withdrawal. You'll be miserable for a couple weeks, and then you'll be a lot better if you make it through those 2 weeks. And that's about what they predict. They do a rapid taper, 2 weeks off, no additional medications. They want to see where you settle out with your RLS before they then add anything back in to treat, and see if you even need therapy at that point. That's rough. It's amazing that people can tolerate this. Dopamine withdrawal is awful. It's awful. So dopamine agonist withdrawal syndrome is total body pain, horrible anxiety. I've had people wind up in the ER because they come down too quickly on their dopamine agonist, and they're having panic attacks. They're suicidal. It causes mood disturbance. Dopamine agonist withdrawal is absolutely horrible. And so our strategy tends to be a little bit slower. I get them off at a much slower pace, and I try to find something else. Hopefully a gabapentinoid works for them. If not, then we end up on opiates, but something to sort of cushion that withdrawal, so they don't call you every day telling you what a horrible person you are for putting them through this. But even in the compassionate protocol, they will suffer their way off these drugs. That's inevitable. You got to warn them about that, but it's short-term pain for long-term gain. They do wind up better. They all wind up better in the long run, but it is a difficult process to get them off the drugs. And then there's the impulse control disorders. There are 4 primary impulse control disorders that we see in patients taking dopamine agonists. It's compulsive shopping, compulsive gambling, compulsive eating, and compulsive sex addictions of various kinds, often pornography. So these are the 4 that we're asking about at every visit. It's not rare. This group at Mayo 13 years ago published a study, 17% of their patients on dopamine agonists wound up with an impulse control disorder. This is not as rare as you might think. I see it all the time. There's a relatively similar risk of any of those 4 different impulse control disorders, and it morphs. So I know of a patient who started with a compulsive shopping addiction, and then it moved to gambling. And $800,000 later, he went into Gamblers Anonymous for them to say, you know, you're on this drug, right? I said, what do you mean? He said, you know, this drug causes the gambling. No, I didn't know that. So this happens to people, and it's a major problem in their lives. And so we really have to be careful. Eating and shopping are the 2 most common by a little bit, not a huge amount. They're the 2 most common that I see, and a little bit higher rates of those 2 in the literature, but really any of the 4 can be really devastating. The risk is highest with pramipexole and ropinirole, more so than levodopa, or the dopamine agonists that we really don't use much of, like pergolide, which isn't even in the United States. So there are other dopamine agonists out there, but these 2, the 2 we actually use, are the 2 that cause it the most. It does seem to be dose dependent. So what happens when people develop tolerance and then they augment and then the dose goes up and up is they wind up with an impulse control disorder. So this is where we get into a lot of trouble. You see these patients on these high doses, you got to get them off. And so the other trick is that it can start years into therapy. So people have been on these drugs, tolerating them fine for 5 years, and then they develop their impulse control disorder. And it makes it very hard for the patients to recognize that this behavior they've developed 5 years into therapy has anything to do with that drug you started on 5 years ago. They're never going to figure that out on their own. Your job is to warn them. If you're starting this drug, you have got to tell them and tell their family, look out for these things. If you see these changes, we need to know about it. The other thing you do is not increase ridiculous dose amounts. So you don't put them on 5-6 milligrams of Mirapex, because you get up to those levels, your rate is going to go up a lot. So you're careful with the dose, you warn them, and then every time they come in, you screen them and you remind them. Say, you haven't developed any of this weird gambling or shopping behaviors or anything. They didn't know? Good. Okay, then continue. But you got to warn them. You got to screen every time. On the whole, the sleep community is pretty down on dopamine agonists at this point, including Dr. Ondo himself. When you hear him talk, he's not big on these either anymore, even though he was the original person who studied it, but it wasn't known at the time that they would cause these impulse control disorders. That information came out about 10 years later. But if you add in the tolerance, the augmentation, and the impulse control disorders, the negatives outweigh the positives. But the positive is that they work, and they always work. So you do have to weigh that. And there is still a role for them in therapy. And my slide stopped at that. There we go. Okay. So just sort of a summary of the protocol that we try to use: iron first, then the gabapentinoids. Gabapentin itself being the cheapest and the easiest, so we usually start there, but pregabalin is fine too. I kind of think pregabalin works a little better than gabapentin, but I'll go for either. Gabapentin and acarbryl is actually hard to get because it's brand name only. If you can get it, it works well for the patients who respond to gabapentinoids. It doesn't work that great for everybody, but it's certainly worth a try if you can get access to it. Then we go to the dopamine agonists. When you've exhausted the gabapentinoids, it's okay to use a dopamine agonist when you've warned them, screened them, kept the dose low. What you can't do is go up on the dose forever, but it's okay to try to manage people with low dose dopamine agonists, because your next line is going to be opiates, and you don't necessarily want to commit people to opiates. Opiates are good. Benzo's not as good. You can see the doses of opiates there. The number one best drug on the planet for restless legs is methadone. It has what I consider to be a 100% success rate in treating restless legs. It has never failed to treat a patient's restless legs. It fails because it's high in side effects. So it causes sedation, it causes constipation. So not everybody tolerates methadone, but it always works. So in my back pocket, when you're seeing these horribly augmented patients, you know you can help them. Hopefully they tolerate it, but you've got something that will calm their restless legs down. Tolerance is amazingly not that common in the opiates. People can take a low dose methadone for a really long time and they never seem to develop tolerance to it. More recently, we've started using Suboxone as another alternative. It's a little better tolerated by a lot of people than methadone. It has a fewer side effects. And now that these X waivers are going away, you don't have to worry about some of the old prescribing rules about getting it. So everybody can prescribe buprenorphine. And sometimes we use plain up buprenorphine. Sometimes we'll use Suboxone as the combo buprenorphine and naloxone. But buprenorphine is really the drug you're going for with these with it because you want the opiate. And there are lower rates of dependence than in other populations. So they've done studies on the risk of opiate dependence in restless legs, and it's very low. So we definitely use opiates when you've exhausted your other options. Sort of the new kid on the block is dipyridamole. There's small studies that show that dipyridamole is helpful. It's an old drug that we used to call Agronox when it was combined with aspirin. Those of you treating strokes in my era or before, we were using this all the time for stroke patients. We don't do it anymore because Plavix came around and other platelet inhibitors, but it increases adenosine. And so when we went through that cascade, increasing adenosine is actually helpful for restless legs, causes headaches, GI distress, and increases risk of bleeding. But it's really good, sort of an I don't want to use augment, additional therapy for restless legs, often in people who want to stay on a lower dose of opiates. You can combine the two and actually keep their opiate dose pretty low. And then you can use any of the above for PRN therapy. I'm fine with levodopa if you just need it for a long flight. You're not going to augment or if you just take it sporadically like that. There are a bunch of non-pharmacological options. They don't make the vibrating pad anymore. Squeezing is good. We call it counter stimulation. You could even get over the counter pneumatic compression devices. Some patients will respond well to that. They probably work for some people. They're welcome to try. I don't really endorse or refute any of them. If they work for you, great. And then future directions. I have to thank my wife for putting this trial on my radar yesterday because a patient of hers asked her about it. And she said, hey, you better know about this. Pitolisant, which we're using for narcolepsy because it increases histamine in the brain, which increases wakefulness. Well, if antihistamines work to cause restless legs, they thought, hey, why not try this drug, which increases histamine, counteracts the antihistamines. Maybe that will help restless legs. Dr. Ando, again, lead PI on this study. So we will see, we may get another drug for restless legs one of these days. Dipyridamole, still very early stages. And then can we better tailor therapy for restless legs using substantia nigra ultrasound to determine who would benefit most from iron? And then there's another trial out there on epigenetics. Can we figure out why this is happening to some people and not others? There's a clear genetic predisposition. And we know Northern European populations tend to be the highest risk. So what are the role of genetics and epigenetics? That is all I've got. Happy to take questions.
I will correct you just a bit.
Okay.
So the restless leg seminar was actually at Bayview, not at Hopkins, my hospital. And someone you didn't mention who was just a giant in the field and lovely guy died a year ago, Richard Allen, just a remarkable, gentle human being. So questions, Joe?
So Andrew, in that subset of people with good ferritin and transferrin levels who you've already given some iron to, you made the argument that you can't trust the blood work. So in that subset, you don't know whether they should get more iron or not. What about looking at their spinal fluid and checking that level?
Just repeat the question.
So the question is about trying to tailor therapy using LPs on the ambiguous iron patients where you're really not sure in their blood if we should be giving more iron or not. Should we be doing the LP and actually getting an answer to that? It's not a bad idea. I mean, we certainly don't do it routinely. And I'm going to be honest, I don't even know if CSF ferritin is a clinical lab I could order if I tried, because I've never tried. We end up just using prescription pills at that point if we're not comfortable giving more iron. And so I'd have to even look to see if I can order CSF ferritin.
Just say it's a very anemic patient. Send it off. That's blood.
Oh, I mean, is it orderable?
Just
I
send
mean,
it off as blood. Just say they're very anemic. That's why it looks like that.
Oh, you mean send the CSF as a blood test? Yeah.
So, I mean, when I was young like you, all we had was dopamine agonists. We didn't know about, people needing more and more doses. And then is the iron theory really accepted by everybody, or is it? Because I remember it being controversial.
So last June, I attended my first meeting of the International Restless Legs Study Group. And I asked the question because I still think it's heterogeneous. I think there are some people out there who have a peripheral etiology. And so I was asking some of those folks who've been in this field, this is the Earlys and Winkelmans and Ondos of the world. And I universally got shot down. Absolutely, it's iron. Don't even think about anything else. I was a little taken aback by just how confident they were in that theory, but it was across the board, absolute confidence that this is at some level iron deficiency related. And they weren't really interested in any other theories.
Why just not like the dementia clinic? We give everyone B12, even though it doesn't do anything.
So
why don't you just give them all iron?
So there is a school of thought, and they are actually starting to advocate. When I said that 75 is probably going to go up, really what we're doing is ruling out iron excess. You check the iron to make sure they don't have hemochromatosis. And if they don't, it's almost certainly safe to give the iron at that point. So we probably should do a trial for iron with everybody who doesn't have hemochromatosis. Worst case scenario, they get a high level and eventually it'll go down again because they don't have an iron storage disorder. So there's definitely a school of thought, and that may be coming, that it becomes standard of care for everybody to just get the IV iron who isn't iron overloaded. So that may be coming.
All right. I'm going a little over time. No more questions on the internet. Katie Moore says, thank you for telling people about the gambling. I can only imagine me on a dopamine agonist. Yeah. So everyone have a great day, and thanks for joining us. And thanks to Andrew and our speakers today.